The important 10 markers we saw: chronic heart failure or heart failure is already completed. This question is also completed. Acute left ventricular failure we completed. And also atrial fibrillation, which is asked once as a 10 marker and asked many times as a 5 marker question. We'll discuss while discussing 5 mark questions. Angina pectoris we discussed, chronic stable angina we discussed, acute MI we discussed. Now we are going on to discuss hypertension, all about hypertension. Under 10 marks, we will be left with mitral stenosis and cardiomyopathies. Cardiomyopathies is asked only once as a 10 marker. So we'll be discussing it under 5 marker question, where it is most commonly asked as a 5 marker. Please note, acute rheumatic failure and infective endocarditis we have studied extensively in our microbiology days. So I will not be touching upon the 11th, 13th and 14th question. I request you to revise acute rheumatic fever and infective endocarditis after this class, because it has been asked as 10 marker and 5 marker many times. Many times it has been asked. It's a very important question. Please go through it after the class. And then MS I will be discussing under 5 marker. So in 10 marker, now I am discussing hypertension, all about hypertension. If you ask previous 5 year RS4, previous 5 year questions, only heart failure was asked as a 10 marker, which we already finished. All others are 3 markers and 5 markers, majority being 3 markers. Let's start with hypertension. Most important and most interesting topic. The definition of hypertension. Please note, the hypertension is defined in this era by measuring ambulatory blood pressure. What is ambulatory blood pressure? Ambulatory blood pressure is a kind of measuring BP, where we tie the cuff to the patient and we'll have a machine and record blood pressure for 24 hours continuously. The machine does it for itself. So the criteria for defining a patient having hypertension is any one of the 3 of this. First one, if the 24-hour mean blood pressure is more than 125/75 mmHg, if the morning mean blood pressure or the daytime mean blood pressure is more than 130/80 mmHg, or the night mean blood pressure is more than 110/65 mmHg, it is considered as hypertension. So in many of the cases, ambulatory hypertension, we can't do ambulatory hypertension in PHC or other peripheral centers. In those centers, we can do the clinic or office BP measurement and or home BP measurement using sphygmomanometer. All of this ambulatory hypertension, ambulatory BP values that I mentioned is taken from American Heart Association guidelines. So we discussed about ambulatory hypertension criteria for defining as hypertension. Next we have clinic or office hypertension, office measurement of blood pressure. The prerequisites before measuring the blood pressure is make the patient sit for 3 to 5 minutes quietly with his back resting. And also please note, 30 minutes before the measurement of BP, the patient should not have consumed coffee, he should not have smoked, or he should not have done any exercise 30 minutes before the recording of BP. All this may impair the BP measurement. First, we'll tie the cuff at the mid-arm and make the arm at the level of heart. During BP measurement, the arm of the patient should be level at the level of heart, and also the lower limb should be touching the ground. By making sure all these things are ticked, we take 3 consecutive BP measurements. Between each consecutive measurement, there should be 1 minute interval. The mean of these 3 measurements will take as final reading. If it is more than 140/90 mmHg, according to European Heart Society, then we'll call the patient to come after 4 weeks. After 4 weeks, we will repeat this. Meaning we'll do 3 consecutive measurements of blood pressure. Even after 4 weeks, if the blood pressure is more than 40/90 mm, 140/90 mmHg, we'll classify the patient as having hypertension. This is about measuring the blood pressure in clinic, which is most commonly done. And what if the patient is rich and has the BP measurement machine in the home? The home BP measurement, he can only take 2 consecutive readings. If it is more than 140/90 mmHg, we'll make the patient to take reading after 4 weeks. And after 4 weeks, if it is above 140/90 mmHg, we'll consider him as having hypertension. We discussed about definition of hypertension, both with respect to ambulatory BP, which is according to American Heart Association criteria, and also we discussed the criteria in clinic measurement of BP or home measurement of BP according to European Heart Society. European Society of Hypertension. This is about the definition of hypertension. Next, let's proceed on to etiopathophysiciology of hypertension. We all know that there are two types of hypertension, that is primary or essential hypertension, which is seen in 85 to 95% of patients. The majority comes here, that is essential hypertension. The another 10 to 15%, 5 to 15% of patients will have secondary hypertension due to secondary causes. In primary hypertension, we can't blame any disease for manifesting as hypertension, meaning we don't have any cause for hypertension in primary hypertension. In secondary hypertension, we have the identifiable cause for hypertension, and we will discuss it shortly. Now, what are the risk factors and etiopathophysiciology of primary or essential hypertension? Essential hypertension is most commonly in 70% of patients. It's hereditary, and we can see family history of hypertension in 70% of patients having essential hypertension. What are the environmental risk factors which lead on to primary or essential hypertension? Those are increased salt intake, uppu jasti tinbardu, obesity, which leads on to obstructive sleep apnea and metabolic syndrome. Why we see primary hypertension in obesity? It causes increased level of leptin, which is released by adipose tissue. This leptin will directly stimulate sympathetic system. The direct stimulation of sympathetic nervous system will cause hypertension in these subset of patients. And also reduced daily activity and exercise is a established risk factor for primary or essential hypertension. Alcohol intake is another risk factor. Low calcium content in the diet is also one of the risk factor for primary or essential hypertension. In these primary or essential hypertension patients, if we measure renin level, it may be low, it may be normal, it may be increased. When there is reduced renin level, if the patient is too much sensitive to salt, meaning the salt excretion from the kidney is not so adequate, it is impaired in some subset of patients. This salt sensitivity will cause sodium and water retention, which in turn causes reduced renin level. These patients are commonly diabetic and old age patients, elderly patients. These patients most commonly respond to diuretics as a treatment. In some patients who are salt sensitive but not so severe to cause reduced renin level, they will have normal renin levels. Those patients are usually males and postmenopausal females. In some subset of patients having primary hypertension, the renin level will be increased. In those patients, giving ACE and ARB inhibitors will be helpful in reducing the blood pressure. I discussed about etiopathophysiciology of primary hypertension, the genetic, environmental causes, and I briefly touched about the renin levels which can be increased, low, or normal. Next, let's proceed on to discuss the secondary causes of hypertension. Please note, the secondary causes of hypertension should be suspected if the patient has hypertension less than 40 years. If any young individuals less than 40 years present to you with hypertension, or if you find out hypertension in less than 40 years patients, please do investigate for secondary causes which are treatable. What are the secondary causes of hypertension? They can be renal causes, endocrine causes, and cardiac causes, serious causes. The renal causes of secondary hypertension are renovascular diseases like renal artery stenosis, maybe unilateral or bilateral, fibromuscular dysplasia, and Takayasu vasculitis involving renal vessels. We discussed about etiopathogenesis of these conditions leading on to hypertension when we discussed nephrology. Then we can have chronic glomerulonephritis like IgA nephropathy, membranoproliferative glomerulonephritis leading on to cause secondary hypertension. We also discussed these points a little bit. What are the endocrine causes of hypertension? The endocrine causes may be genetic or it may be acquired. The genetic causes of secondary hypertension are Liddle syndrome, where there is increased activity of ENaC channels, the channels which are stimulated by aldosterone, responsible for salt and water retention. If these ENaC channels are hyperactive, we'll get secondary hypertension. Or Jeller syndrome, where we have mutations, gain of function mutations of mineralocorticoid receptors, collecting the nothing but increased activity of aldosterone, which causes again increased activity of ENaC and sodium and water retention. These are the genetic causes. Now, what are the acquired endocrine causes of secondary hypertension? The acquired endocrine causes of secondary hypertension can be due to adrenal issues or due to thyroid issues. The adrenal issues causing secondary hypertension are primary hyperaldosteronism. There is increased aldosterone levels and its activity. It is characterized by a triad of hypertension, hypokalemia, and metabolic acidosis. Why? Because the ENaC channels are responsible for reabsorption of sodium and excretion of potassium and H+. When there is increased activity of this channel, there will be increased reabsorption of sodium leading on to salt and water retention and hypertension. When there is increased excretion of K+, leads on to hypokalemia. Increased excretion of H+ leads on to metabolic alkalosis. The other cause of adrenal disease causing secondary hypertension are Cushing syndrome, where there is increased activity of cortisol, which directly stimulates the heart. The another cause is pheochromocytoma. Pheochromocytoma is adrenal medullary tumor secreting norepinephrine and epinephrine. The norepinephrine and epinephrine, we already know, is responsible for vasoconstriction, so it causes hypertension. Both hyperthyroidism and hypothyroidism can cause secondary hypertension. So when you are doing investigations for secondary hypertension, please do TFT along with the renal artery Doppler, and other investigations. The serious causes for secondary hypertension is coarctation of aorta. We discussed the secondary hypertension causes, renal, endocrine, and serious causes. By this, we are ending the etiopathophysiciology of hypertension, that is both primary and secondary. Let's continue to discuss about clinical manifestation of hypertension. Majority of the patients are asymptomatic. Since majority are asymptomatic, we don't pick up the hypertension quickly, and most commonly, most of the patients presents with target organ damage, which is very, very bad, very, very bad, very, very bad. So what are target organ damage? We'll discuss it shortly. If the patient has acute increase in blood pressure, he may present with headache and polyuria. And also we discuss so many secondary causes. If the patient has secondary causes of hypertension, he will have the signs and symptoms which are associated with these secondary causes. You can mention this under this heading. On examination, we can see fundal changes on ophthalmoscopy, direct or indirect. We can see fundoscopic changes, which we'll discuss shortly. And also due to left ventricular hypertrophy secondary to hypertension, the hypertension increases the peripheral vascular resistance. Increased peripheral vascular resistance inside the blood vessels will cause back pressure. Here the resistance is increased, will have back pressure, and it will cause left ventricular hypertrophy. So due to left ventricular hypertrophy, we may have heaving apical impulse, and in some patients you can also hear S4 sound, heart sound. These are about symptoms and signs that we see in the patients with hypertension. Now, what are the acute complications like hypertensive emergency, hypertensive crisis, hypertensive urgency? What are these things? What are the difference between all these things? We'll see. Before that, let me explain what are the target organ damage, which is separately asked as 5 marks question. So please pay attention. We have CNS complications, ophthalmological complications, serious complications, and complications related to blood vessels, that is aorta most commonly. What are the CNS complications of hypertension? The dreaded complication, that is hemorrhagic stroke. Since most of the patients are hypertensive for asymptomatic, for many years they will have hypertension, which lead on to the pathophysiological process leading on to stroke, and finally one day the patient presents with hemorrhagic stroke. And some patients may have transient ischemic attacks. These patients are a little bit less than patients present with stroke, because we can intervene in these patients and prevent the occurrence of stroke. We have another CNS complication of hypertension, that is posterior reversible encephalopathy syndrome. What is this posterior reversible encephalopathy syndrome? Press. When the blood pressure is markedly increased acutely, it may lead on to diffuse cerebral edema, which causes impairment in speech of the patient, impaired consciousness of the patient, and also the patient will have seizures. While discussing seizure, I'll mention this point again. It is one of the cause of seizure, generalized tonic-clonic or focal. I'll explain this when I explain about seizures in neurology. These are the CNS manifestation, that is stroke and stress syndrome. What are the ophthalmological manifestation? We have hypertensive retinopathy. Keith Wagner-Barker classification, I'll just go through it. In grade 1, the patient will have mild narrowing of arterioles. In grade 2, the patient will have binding sign, Salus sign, and then associated with it AV nicking and copper wiring. In grade 3, the patient will have severe narrowing, silver wiring, cotton wool spots, hard exudates. And in grade 4, along with grade 3 manifestations, the patient will have papilledema. We'll see this manifestation, why this manifestation occur when we discuss hypertensive retinopathy under ophthalmology. What are the serious complications of hypertension? We have coronary artery disease. Coronary artery disease, the patient may have acute MI due to this, or may have secondary arrhythmia like atrial fibrillation. Hypertension is one of the risk factor for the patient to develop atrial fibrillation. It may be secondary to coronary artery disease leading on to atrial fibrillation also. And also the patient can develop due to left ventricular hypertrophy. Eventually the patient will develop heart failure. What are the vascular complications? We have aneurysm and dissection of aorta. Life-threatening complications. These are life-threatening complications. Patient will crash and it's associated with high morbidity and mortality. The aneurysm and dissection. This is about the target organ damage. These are CNS, ophthalmological, CVS and blood vessel complications. Let's proceed on for acute conditions seen in hypertension, that is hypertensive crisis or emergency and hypertensive urgency. What is the difference between hypertensive crisis or emergency and hypertensive urgency? Is the signs and symptoms of acute end organ damage. If the patient has signs and symptoms of acute end organ damage, we'll classify that patient as having hypertensive crisis or emergency. Or if the patient doesn't have any signs and symptoms of acute end organ damage, we'll tell the patient has hypertensive urgency. I'll go through it in deep now. You'll get to know about this. I'll also repeat this at last. First, what is hypertensive crisis or hypertensive urgency? Emergency, not urgency. Sorry for my mistake. Please note, it is hypertensive crisis or emergency. Emergency. What is this hypertensive crisis or emergency? Hypertensive crisis or emergency is a condition where there is acute increase in blood pressure of the patient. Please note, there is no cutoff for BP in hypertensive crisis or emergency. But we usually see systolic blood pressure to be between 180 to 220 mmHg and diastolic blood pressure between 120 to 130 mmHg in case of hypertensive crisis or emergency. It's not the criteria defining this, but we usually see these values. BP, the patient should have signs and symptoms of acute end organ damage to call a patient as having hypertensive crisis or hypertensive urgency. Now, what are these signs and symptoms of acute end organ damage? The patient may have severe headache. Why severe headache? When there is acute increase in blood pressure, the cerebral vasculature autoregulation get impaired. This leads on to arteriolar spasm, and when there is increase in blood pressure, the hydrostatic pressure has increased. There will be outpouring of fluid from the blood vessels, cerebral vessels, leading on to diffuse edema inside the cranial cavity, diffuse cerebral edema, which leads on to severe headache in the patient. What are the ophthalmological manifestations? The patient may have acute hypertensive encephalopathy, hypertensive retinopathy. He may have grade 4 hypertensive retinopathy leading where papilledema can be seen. So, doing ophthalmological examination, direct or indirect ophthalmological examination, fundus examination in case of hypertensive urgency or emergency is helpful because it picks up papilledema, which diagnoses the patient as having hypertension, emergency or urgency. So we can have severe headache, ophthalmological manifestation. Also, the patient may have focal or generalized seizures, which may be due to the posterior reversible encephalopathy syndrome. These are all the definition and signs and symptoms of hypertensive crisis or hypertensive emergency. Now, why this patient will have hypertensive crisis or emergency? It It may be due to pheochromocytoma there, where there is rapid release of epinephrine, primary hyperaldosteronism, which leads to acute increase in blood pressure. And also in case of eclampsia patients, there may be acute increase in blood pressure leading on to hypertensive crisis or emergency. Please note, the malignant hypertension, or also called as accelerated hypertension, posterior reversible encephalopathy syndrome, and aortic dissection are part of hypertensive crisis or emergency. These are all the subset of manifestations which are seen in hypertensive crisis and emergency. What is malignant hypertension or accelerated hypertension? Malignant hypertension or accelerated hypertension is being asked as 5 marks question many times, so please pay attention. In malignant hypertension or accelerated hypertension, there is rapid increase in blood pressure with diastolic blood pressure more than 120 mmHg with end organ damage. And also on histopathology, we will see fibrinoid necrosis around the blood vessel with thrombosis of the vessels due to this. How to diagnose malignant hypertension? If the diastolic blood pressure is more than 120, grade 3 or grade 4 hypertension retinopathy, or the patient have acute renal dysfunction, or the patient has press along with acutely increased BP, will classify that patient as having accelerated hypertension or malignant hypertension, which is a subset of hypertensive crisis or emergency. The patient may also have aortic dissection, which I mentioned. It is a subset of hypertensive crisis or emergency. One of the end organ damage manifestations seen in hypertensive emergency or urgency. Please note, if you don't treat malignant hypertension or accelerated hypertension patients adequately, in few months you will have death because of renal dysfunction and associated clinical manifestations or clinical symptoms, clinical conditions. This is all about hypertensive crisis or emergency, where we discussed the definition of hypertensive crisis or emergency, the causes of it, the subset of it, where we discussed briefly about malignant hypertension or accelerated hypertension. Now here we saw in hypertensive crisis or emergency, there are manifestations of signs and symptoms of acute end organ damage. If the patient has only BP more than 180/120 mmHg without any manifestations of acute end organ damage, the patient will be classified as hypertensive urgency. In hypertensive urgency, within 24 hours, we should give adequate agents, antihypertensive agents, and control the BP. That is the target in case of hypertension urgency. Within 24 hours, we should treat the patient. Now you'll ask, Kritik, you mentioned so much about hypertensive crisis or emergency. What is the treatment for it? How to manage it? The management of hypertensive crisis or emergency and malignant hypertension. Obviously, we'll try to reduce the mean blood pressure of the patient. Please don't be over enthused and reduce the blood pressure quickly. If you reduce the blood pressure by giving IV agents, we have many IV antihypertensive, we'll give it and reduce it. If you do that very rapidly, the patient will have reduced perfusion to myocardium, to cerebral perfusion. All the perfusion will be reduced, and he may develop MI due to that. Please note, so our target is, we should not decrease the mean BP more than 20 to 25% in minutes to hours, 2 hours. Meaning, we will decrease the mean BP by less than 20 to 25% in minutes to 2 hours. And diastolic blood pressure will only should be decreased to 100 to 110 mmHg. Please don't take below that. I hope all of you understood this point. So this timeline for managing blood pressure can be more aggressive if the patient has pulmonary edema and aortic dissection, because reducing BP quickly is important in these two conditions. We have to be much more slower, much more delay the reduction in blood pressure in case of acute cerebrovascular accident like hemorrhagic stroke. What are the IV agents used? Labetalol, sodium nitroprusside, nitroglycerin, hydralazine, etc. Many drugs we have in our pocket. Okay, this is about management of hypertensive crisis or emergency. We finished the acute conditions in hypertension, that is hypertensive crisis or emergency, and hypertensive urgency, malignant hypertension. And we saw the clinical we are finished with idiopathogenesis, clinical manifestations along with target organ damage. What we are left with? So now we are left with investigations and treatment of hypertension. What are the investigations that we should do in case of hypertension? First, BP measurement. To diagnose BP, hypertension, first we should measure BP. BP measurement, I explained extensively when I explained about definition of hypertension. You can mention this under investigations and BP measurement. What are the, so we know there are many renal, endocrine and serious causes causing hypertension. So we should investigate in order to find whether the patient has secondary causes. To find out the causes, renal causes, we'll do renal artery Doppler, where we can pick up renal artery stenosis. We can do RFT, urine albumin and urine creatinine ratio, to find out whether the patient has chronic glomerulonephritis. We should do serum estimation of sodium and potassium level, which may be impaired in case of secondary hypertension. We should also do, and also estimation of serum sodium and potassium levels help us to find out if the patient has primary hyperaldosteronism, where we see increased sodium levels and decreased potassium level, that is hypokalemia. We should also do TFT, thyroid function test, because we know post hypo and hyperthyroidism is a secondary cause of hypertension. We can do 24-hour urinary fractionated metanephrine estimation to find out whether the patient has pheochromocytoma. In case of pheochromocytoma, the norepinephrine and epinephrine will be broken down to metanephrine's. So estimation of this level will help to find whether the patient have pheochromocytoma. Please note, the calculation of central systolic blood pressure is the most reliable marker of end organ damage. This is about investigations in case of hypertension. Now, how do you treat the patient? You have diagnosed now, around sitting. No, you should treat. Why? Because if you don't treat hypertension, the patient may land up in stroke. He may land up in hypertensive retinopathy. He may land up in other complications. So you have to treat hypertension compulsory. If the patient has blood pressure value between 130 to 130 bar 80 mmHg, more than or equal to 130 bar 80 mmHg, we usually don't treat these patients. We advise lifestyle modifications. If the patient having blood pressure value more than 130 bar 80 mmHg has coronary artery disease, we can give monotherapy, that is beta blockers or other drugs. If the patient has grade 1 hypertension, what is this grade 1? Let's see grades of hypertension. If the patient has values between 130 to 139 mmHg and 85 to 89 mmHg, it is high normal. Between 140 to 159 mmHg and 90 to 99 mmHg, it is grade 1 hypertension. Between 160 to 180 mmHg and 100 to 109 mmHg, it is grade 2 hypertension. More than or equal to 180 and more than 110 is the grade 3 hypertension. We have seen this category comes under hypertensive urgency. If it has end organ damage manifestation, it comes under hypertensive crisis or emergency. So, if the patient has grade 1 disease, if the blood pressure is more than 140/90 mmHg, for first 4 weeks, we suggest lifestyle modification. That is a reduction in weight, which is very, 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 very difficult. The patients will not easily reduce their weight. And also decrease the intake of salt, increase the intake of potassium and magnesium. You can suggest banana, which is rich in potassium. Potassium increase is found to be beneficial with respect to increased sodium level seen in some patients. And also more, we'll tell the patient to be stress free. It is not possible in case of medical students. We can't be free of stress. So okay, we can advise the patient to quit smoking, and also we should advise the patient to have daily activities and exercises. We'll do this for 4 weeks. For 4 weeks, the patient does this. Most commonly, no one will do this. If there is no change in blood pressure after 4 weeks, we'll go to give drugs to manage hypertension. If the patient is less than 65 years, the target blood pressure for us after treating hypertension is 120 to 130 systolic and 70 to 80 diastolic. The target after 65 years will have fibrosis of the vessels, so the target is increased. After treatment, we should aim to reduce the systolic blood pressure to 130 to 140 and diastolic to 80 to 90. There is 10 mmHg between these two values, which will help you to remember. And also, if the patient has blood pressure more than 150 to 150/95 mmHg, please don't suggest any lifestyle modification. You start with pharmacotherapy. Now, what are the drugs that we give in case of hypertension? We have first frontline drugs, the frontline warriors, ACD, not ABCD, ACD. The ACD are ACARB inhibitors, calcium channel blockers, and diuretics. The beta blockers are only given if the patient has some indications for beta blockers, or else we don't usually prescribe beta blockers. We can give it in coronary artery disease patients. The first condition, monotherapy, we can give beta blockers. Now, according to European Society of Hypertension, first we'll start with ACARB inhibitors and calcium channel blockers. 60% of patients respond to the AC treatment. AC, 60% response. Another 40% will not respond. We will add on diuretics for them. AC not working, add D. In that, after giving A, C and D, 90% of patients respond. The remaining 10% Papa, they will not respond to all this treatment. If they don't respond to all this treatment, that is ACD, please check for secondary causes of hypertension. The patient may have reversible secondary causes of hypertension. If there is no response to 3 drugs, ACD, given at a maximal dose, and there are no other identifiable secondary causes, the patient will be classified as having resistant hypertension. Resistant hypertension is a 3 marker, so please note this. If the patient has resistant hypertension, we'll calculate the GFR, eGFR, effective GFR of the patient. If it is less than 30 ml per minute per 1.73 meter square, less than 30 ml per minute per 1.73 meter square, will give the thiazide diuretic, that is chlorothalidone. If it is more than 30 ml per minute per 1.73 meter square, will prescribe spironolactone or the mineralocorticoid receptor blocker, that is spironolactone. In case of resistant hypertension, we have one procedure that can be done, that is percutaneous transluminal radio frequency sympathetic denervation of renal arteries. Don't get foxed by this big term. This is nothing but the sympathetic nervous system around the renal arteries. We are just excising lips. The excision using radio frequency denervation of this sympathetic nerves will help to reduce BP in some patients. So this is all about definition, idiopathophysiciology, clinical manifestations, and management of hypertension. So the ambulatory BP, if any one of the three criteria of this is classified as hypertension, the home or clinic blood pressure more than these values is considered as hypertension. Now, what is the idiopathophysiciology? We have primary and secondary hypertension. The primary hypertension, genetic, environmental causes, and the renin levels which can be seen. The secondary hypertension, we have renal causes, endocrine causes, and serious causes. The clinical manifestation, we saw that most of the patients are asymptomatic. Under symptomatic, we have the symptoms of secondary causes and acute manifestations like headache and polyuria. On examination, we can see fundal changes, ophthalmological changes, left ventricular hypertrophy, related manifestations like heaving apical impulse and S4. And also, we saw target hormone damage in case of hypertension, the CNS, stroke and press, ophthalmological manifestation, serious and aortic aneurysm and dissection. The acute manifestations of hypertension, that is hypertensive crisis or emergency, and hypertensive urgency. After that, we saw investigations and treatment done in hypertensive patients. The investigations are BP measurement and secondary causes related investigations. The treatment is different for three categories. More than 130/80, we do monotherapy only in coronary if the patient has coronary artery disease. In grade 1 or more than 140/90, we'll do four weeks lifestyle modifications. If not, we'll give drug therapy, starting with 2 drugs, AC, followed by adding of D. And then if there is no response, we want resistant hypertension. So the resistant hypertension can be treated with spironolactone and chlorothalidone. We saw if the patient has BP more than 150/95 mmHg, we'll start the drug therapy immediately.